The patient in this video had a large cholesteatoma that was removed. The eardrum was reconstructed with thin-cut sheets of cartilage, and I used an intact canal wall procedure. I am looking through an ear speculum. At this point, I'm measuring the location where I need to access the mastoid and get into the middle ear through the posterior tympanotomy so as not to disturb the recreated eardrum, which has healed very nicely and is solid. I use the upper third of the incision and place a small retractor. I open the mastoid, and during the first stage of the procedure, a silicone sheet has been left in place which helps support the position of the cartilage and the graft for the new eardrum. Here you can see that there is a movement of the stapes and a good movement of the cartilage graft that is healed nice and flat due to the placement of the silicone. I am estimating the distance and the tension that I need to place the prosthesis between the superstructure of the stapes and the undersurface of the new eardrum. I use an Alto-style adjustable prosthesis made by Grace Medical because I can expand it even once it is in place in the middle ear. Using the angled picks, I am estimating the size that I need to cut the prosthesis. The prosthesis has small ball notches that slides through a Teflon sheath in order to adjust the size. Titanium is a very biocompatible material, so it is very useful and safe. I'm adjusting and feeling in this case that the tension is a little too hard, so I will shorten the prosthesis just a bit more to get it into proper alignment and position. I will trim it down to a slightly smaller size. I always try to make it just a little bigger initially, check the tension, and then reduce it to the optimal size and safe placement. Now I am lifting it and putting it on top of the stapes and then adjusting it into a good angle so that it is nicely snug underneath the new eardrum that has been created with a good thin cartilage support. Using a straight pick and an angled pick, I then hold the prosthesis stiff so it does not go medially down and injure the stapes, and then expand the prostheses one notch so that I have a nice, good tension and good position. And given that the prosthesis is in a good firm position, I typically return the patient to full activities without limitations, especially when a partial is used with an intact stapes superstructure. In this video, I will demonstrate the ossiculoplasty technique using the natural incus. This patient has a discontinuity of the incus and the stapes due to chronic ear infections. You can see here that the incus is not connected to the stapes, and there is a large amount of surrounding inflammatory disease. I have already completed a mastoidectomy and removed the incus. Now we are cleaning up any inflammatory debris, and now I am palpating the stapes superstructure to see that it is intact and mobile. Here is the tensor tympani tendon, which connects to the malleus to give support to the malleus when I interpose the sculpted incus between those two structures. The yellow line denotes a segment of the long process which needs to be removed, and then the body of the incus needs to be foreshortened so it does not have excessive mass or weight, and fits nicely in between the stapes and the malleus. Notches are created so that the incus sculpture will fit and hold in position between the stapes and the long handle of the malleus. Now I am shortening the incus in the region that will sit on top of the stapes. Now I am removing some of the bulk mass of the incus. And now I am lowering the profile so that the incus is not excessively high and allows for a good connection between the stapes and the malleus long process. An incus interposition is a very stable reconstruction because it is less subject to erosion due to its natural formation and shape as a natural ossicular bone. I am placing it in position first before any tympanic membrane reconstruction, just to be sure that the size and the contacts are correct. Here you can see how it sits nicely with good mobility between the stapes and the malleus left in position. I am using both a posterior tympanotomy view as well as a transcanal view. Now we are looking through the posterior tympanotomy. Now I have completed the initial stages of the eardrum reconstruction and then placed the incus underneath the malleus, which already has a fascia graft in position. I surround the incus with absorbable gelatin material to prevent it from falling or moving out of position. Once I have it nicely secured, then I will complete the eardrum reconstruction or tympanoplasty. In this video, I'm going to demonstrate an endoscopically assisted second look and placement of a porp after cholesteatoma. You can see the well-healed neotympanum. I use the upper third of the incision right over the mastoid to open up a mastoidotomy to gain access through the posterior tympanotomy into the middle ear. In not all cases can you get a good view to make sure there has not been a recurrence without the use of the endoscope. But in some instances you can, especially given the original location of the cholesteatoma. This patient had extensive cholesteatoma filling the mesotympanum. You can see with the 30-degree endoscope I can get a very nice view of the undersurface of the reconstructed cartilage graft after the silicone is removed, and you can see the charred areas where a laser was also used to help eradicate the initial cholesteatoma, and over to the right is the mobile stapes superstructure. Now at this point, I am introducing the Alto-style expandable partial ossicular reconstruction prosthesis, initially under the microscope. And you can see it is in good position on the stapes, but I feel that it is a little bit on the loose side. So I will expand it, as I showed in the previous video of the expanding porp, to get it under good tension with the undersurface of the previously placed cartilage graft. The endoscope can then be used to also assess the tension and see that it is well positioned underneath a mobile segment of the cartilage graft. I can also reposition it and test it for mobility.